Lucia Hollowell. I'm a social worker with the inpatient team of palliative care at Stanford Hospital.
All right, Jeannie.
Hi, everyone. I'm Jeannie Zanetti, nurse practitioner in palliative care at UCSF MERI Center.
And Ramy.
Hi, everyone. I'm Ramy, Salah. I'm a palliative care doctor, outpatient with the Alto Medical Foundation in San Mateo.
And Gail.
Hi, I'm Gail. I'm the program manager at the MERI Center, and I'll be moderating the Q&A. So if you have questions, please pop them in the Q&A box.
Great, thank you. Just a quick intro about Zoom today. As Gail said, if you have a question, please put it in the Q&A box. If you're not familiar, just type your question and click send. We will not be using the chat, we won't be using the hand raising. But there will be hopefully plenty of time at the end for Q&A. And just a quick overview of what we're doing here. I think there's a new slide, but there we go. I'm going to give you a brief definition of palliative care, and believe me, there are many different definitions, so this is just one. And then we're going to have a panel discussion that's going to be based on a case scenario, so that you can really get a sense of what an interdisciplinary team looks like in palliative care, and then we'll have a Q&A. So palliative care, like I said, there are many definitions. The one we're kind of using as our overall today is the palliative care is a philosophy of care as well as a type of medical care for people who are living with serious illness. And it's focused on providing relief from symptoms and the stress of a serious illness. And the goal of palliative care is really to improve quality of life for both the patient and their family, whoever their caretaker circle is. And it takes into account not just physical suffering, not just medical issues, but mental, emotional, psychological, and spiritual suffering that we know accompanies serious illness. Palliative care is often provided by a specially trained team of physicians, nurses, social workers, chaplains, sometimes volunteers, sometimes pharmacists, everyone working together with all of the patient's doctors to provide the kind of support that they need. One of the things that gets confusing is that palliative care is appropriate at any age and at any stage of a serious illness. It can be provided along with curative treatment, and palliative care is not the same as end-of-life care. So with that, hopefully we're all basically on the same page. I'm going to give you a little bit of background about the case that we are going to be discussing today. So our outpatient palliative care team is preparing to see Mrs. Jones for the first time in clinic. Mrs. Jones is a 66-year-old woman who was diagnosed with lung cancer about a year ago. She has been on chemotherapy treatment since her diagnosis. Unfortunately, her cancer was found to have spread to her ribs about a month ago, and her oncologist has referred her to palliative care because of worsening pain in her ribs over the last couple of weeks. So I'm going to ask each of our panelists, what would you be thinking at this point? What would you want to know a little bit more about? And let's start with Lucia.
Hi, everyone. So this is speaking from the social work perspective on the team. I think one of my first questions for Mrs. Jones would be, how is she coping with this? This is a new diagnosis, a potentially terminal diagnosis. So I'd want to know how she's doing emotionally, how this might be also affecting how she's functioning at home. What is her physical function, or what is her disease burden been at home? I'm wondering if the pain that she's feeling has prevented her from any other care or getting access to food and things like that. The next thing I'd want to ask her about is her social support. is there anyone currently involved that's helping her at home or in her life, or potentially other people she'd like to get more involved with? Those are things that would certainly be on my mind. And then the last piece would be thinking about her financial resources and assessing to see if she has some financial distress. I think you might be muted, Red Wing.
Judy, what would you be thinking about?
So as the chaplain on the team, I would be really interested in a couple of different things. I'd like to know what she turns to, what she finds supportive for herself. So I'd be really focusing on how does Mrs. Jones remember, or can I help her discover any spiritual or religious resources that might help her in the process of her healing. And when I'm talking about healing, because she is dealing with serious illness, I'm not talking about curative healing from a disease, but what is it that heals her heart? What is it that brings her some sense of peace? And as I'm getting to know her, and every one of us is different, then I'm going to be looking at who is she? Who is she as a person? And I want her to feel safe with me so that we can talk. So I'll be establishing rapport, getting to know her, and looking at, the areas of, what's most meaningful to her in her life. Is she connected with a spiritual community, or is she connected with community, period? Because these connections are so important, since we tend to isolate ourselves often in the midst of serious illness. And then I'd be curious if there's anything that she finds that she turns to, as I'd said earlier, that she can do. She may not be able to wave a magic wand and make the illness go away, but what is it that supports her in that she can actually do for herself or do for her family that gives her some sense of agency?
Great, thank you, Judy. Ramy, what would you be thinking about this patient?
Yeah, so as the doctor on the team, and part of the reason, or the reason why the oncologist made the referral to the palliative care team in the first place, which is often the case, is the physical pain that she's been having. And when I think about the physical pain, my mind goes to a set of questions that I really want to figure out how the pain is affecting her, and then in turn, how to best treat that pain. So I really want to hear about what makes the pain better or worse, what she's been taking or not taking. What does the pain feel like? Does it spread to any place, or does it stay in a certain place? Is there any association with time in the day where she feels the pain is at its worst? And probably most importantly, I would want to spend some time with her to discuss the goals of pain management. Many times, it became common practice in the 90s and up till now, asking about a pain number to rate the pain on a numerical scale. And I don't see much utility, because one person's 6 might be another person's 2. But instead, I'd like to frame it as, well, Mrs. Jones, when the pain is at its worst, what does it limit you from doing? And if we were able to achieve pain control, what is something that you would want to accomplish or be able to do? And therefore, we have a goal to shoot for, to work towards, so that hopefully it could bring some quality of life towards to her. And then I'll start thinking about pain. Cancer-related pain is some of the hardest pain to go through. I can only imagine that type of pain. And the tools that we have developed include medications many times, and opioids, being opioids, are very effective for cancer-related pain. But it does require a sit down and a talk, a frequent dialogue. I often say right off the bat that there should be one clinic managing a person's opioids. We talk explicitly about the opioid crisis and how we can avoid certain pitfalls that can occur from starting from prescription medications. So I spend about a good amount of time going into that too, knowing that opioids can be a very powerful medication to help achieve those goals we set out to.
Thank you, Ramy. And Jeannie, how would you approach this?
I think from the nursing perspective, and as a nurse practitioner, just piggybacking, I think, both off social work with Lucia and as a physician with Ramy, I would also want to dig into a little bit more of the symptoms affecting her. Does she have any nausea? Is there any constipation? Is there any fatigue? And so just kind of rounding out what other physical symptoms are really burdening her and chipping away at her quality of life. And then with those symptoms, for instance, like nausea and constipation, what has she tried? What has helped? And then creating a plan to treat those particular symptoms. And I think if we had more time in the visit, I would also want to dig into really hearing from her if she has any fears and worries. So a little bit more about how she's feeling about the trajectory of her disease, and really exploring a little bit more of her values around what's important to her.
Thank you. Thank you all so much. So I'm going to give everyone a little more information about Mrs. Jones. So Mrs. Jones works as a regional bank manager. She's divorced. She has an adult son who lives about an hour away, an adult daughter who lives in New York. She describes that her son helps with taking her to medical appointments, and that she and her daughter talk regularly on the phone about how she's doing. She's taken some time off of work for a couple of weeks, and she's really wondering, am I going to be able to go back to work, and when? She describes herself as not a religious person, but that she is definitely a spiritual person. And some days she wonders why this has happened to her. She didn't smoke, she rarely drinks alcohol, she exercises regularly, she's done everything right. She feels like she's been a good person, and why me? And then in terms of her pain, she kind of describes it as a deep ache, sometimes a stabbing sensation in her right ribs. She hasn't taken anything for pain other than ibuprofen, but the pain has been so severe that she had to stop working over the last couple of weeks, and that's been a little scary for her. She does use the electronic messaging system pretty easily in terms of communicating with the healthcare team. She likes using it. She tends to call the clinic if it feels like there are more urgent issues. She's okay if you reach out to her son if needed, because he is the one who helps with picking up medications, remembering instructions for her. He kind of tries to keep on top of the details. But she's anxious. She's anxious about her cancer. She feels like her family is supporting her well, but she's a bit worried about them also. So hearing all of this more detail about Mrs. Jones, can each of you just talk about what are your next steps? What would you recommend? And how would you collaborate with each other to really just help care for this patient? And we could start with Judy from the chaplaincy point of view, but then it can just be a conversation.
Thank you, Red Wing. You've spoken of so many things that are alive for her right now. So from chaplaincy point of view, I would want to explore some of these areas with her. It could be something like talking about her relationship with her son and what's that like and where is he and how often does she see him? Not because I want to know a specific answer, I just want to get a sense of what her relationships are and how they're going for her and how they're supportive to her. The fact that she's anxious is so normal. I would probably want to spend a little time just normalizing the reality of that. I don't know that any one of us could go through a journey with a serious illness without feeling some anxiety. But I might want to ask her, how does that play out for her? How does that work for her? And then maybe we'd explore some avenues of things that might support her that are non-pharmacological. She said that she's spiritual, or Red Wing, you've let us know she has said that she's spiritual, but not religious. So I'd ask her too, what does that mean for her? Is there a community she's connected with? And is she involved with that community now? So I'm going to stop there because I'm afraid I could probably talk the rest of the time about Ms. Jones, the things I'd love to explore with her. But I'd love to ask Lucia, and I'd love to ask the rest of you, Jeannie and Ramy, what do you think?
I'll go next. So this is Lucia, social worker here on the team. I think for me, a couple of things that I'd be thinking about now, especially in regards to Mrs. Jones needing to take time off of work, I'd want to explore that more with her, and I could provide information about short-term and long-term disability. Of course, I'd be working in concert with the rest of the team regarding their recommendations and thoughts on Mrs. Jones's ability to return to work, but I potentially could provide education about disability and then also assist with some of the paperwork there. The other thing that I would be thinking about, she mentioned that we're okay to call her son to provide medical updates. I'd want to ask her if she's ever completed an advance directive or named a formal, durable power of attorney or surrogate for healthcare decision-making. If she hasn't done that, I can also provide that paperwork and some advice and direction of how to complete it. And I would strongly encourage that. I think that's important for any of us, no matter if we're living with a serious illness or not, to start to have those conversations. I might also make a referral to our chaplain on the team, to Judy, especially when she's asking questions about why is this happening to me? And I would maybe think there could be a meaning-making opportunity to explore that more with her spirituality. And then the other thing, again, with the anxiety that she's experiencing, I'd want to normalize it just like Judy, and to see how she's managing that, how she might have managed that in the past, if she's currently service connected with a counselor or a therapist or has supportive people in her life to process all of those thoughts. And then if she's open to it, I might also introduce some anxiety coping strategies and work with her on those and really concrete tools that she could take home. I'd want to ask her about her sleep and how that's going. And I may make a referral to our nurse practitioner or our doctor because there may be medications. But I'll leave it there for now. So thank you.
I can go next. I would be working very closely with Lucia and Judy in terms of pain management, knowing very well that physical pain is not just experienced on its own, but spiritual and existential pain, along with social pain, emotional pain, can really feed into the physical pain pathways we have in our bodies. And so it's very important to know other sources of pain that may be exacerbating the physical pain she's feeling in her ribs. I'll be talking to Lucia closely about what's keeping her away from work. It sounds like the pain kept her away from work these past 2 weeks, but also what is her reason to return to work? Is she feeling financial stresses where she needs to get back to work? Is it a quality of life thing? Could she never imagine life without working and having her identity in the bank as a worker? And so working with that, and then using the medications that we have. It sounds like she hasn't tried much. She's tried ibuprofen. She may have felt some relief, but knowing that, again, when cancer spreads to bones, that type of pain can be very difficult to experience and debilitating. And so a stronger pain medication may be reached for and used. But before I do that, before I write the prescription for that, I always ask about a person's preference in terms of pain management with these medications. Some people would want, pain control, even if it comes with the trade-off of not being fully aware or being a little drowsy or a little slow. And others would rather go through pain if it meant them being more lucid. And where does Mrs. Jones fit in that spectrum? And this way we can try to work towards a sweet spot for her where we honor her quality of life in the way she defines it for herself. And then in terms of meaning making and, these tough existential questions that I'm sure Judy would be helping address with Mrs. Jones, I would want to pay attention to her physical pain. If she does find some sort of reprieve from those difficult questions, the pain associated with that, how does her physical pain change with these conversations or these meetings with Judy or Lucia? So I'll stop there. Hopefully we can get better pain control for Mrs. Jones, and I'll turn it over to Jeannie.
Everyone, Jeannie, from the nursing perspective, I think things have been so thoroughly covered by Judy, Lucia, and Ramy. I think the one thing that I would add, though, would be just, I think, a more in-depth look at all medications she's taking and just making sure that we're really helping her manage her medications. And so if Ramy's prescribing, let's say, an opioid or some additional pain medicines, and she's already taken other medicines, and then she's also getting her cancer-directed treatment on top of it, it would just be really looking through and making sure that she's taking the medications safely, appropriately, and that the doses are correct, and that she has enough support at home that she's able to either manage them on her own or need some help from her son or additional family members. And if appropriate, if she's struggling with that, that's often when a home health nurse can come in really, really handy in terms of helping to manage medications in the home, and making sure that she's also safe in the home, right? If she needs a little physical therapy help in the home, to making sure that her functioning is as optimized as possible. So those are the additional things that I would add to the rest of what the team has said.
Thanks a lot, Jeannie. I'm going to give you one more little, go ahead, Jeannie.
Oh, please go. I was just going to say, I love the idea that we all kind of bounce things off one another. I think it's so helpful. Like even Lucia just reminding me, but she had existential distress. You'll just make a referral back. But the fact is that's someplace that I would spend a lot of time with her initially. And the fact is, in real life, we all do that for one another as a team, which I think is really helpful to us and hopefully helpful to the patient and her family and her son, so that we're all together in this, which is one of the things I love about palliative care. And I'm sorry, Red Wing, you were just about to share something, but I just had that on my radar.
No apologies needed. So I just have a little more information for all of you about Mrs. Jones, which is that 3 days after her initial visit, she calls the palliative care clinic. And she had a new medication prescribed by the palliative care doctor, but now she's having some nausea, she's having some constipation. She's a little worried about that. She's wondering, okay, now what are the next steps? She's also starting to think, maybe I should get connected to a support group. Would that really help me a lot? So I'm going to ask Jeannie to start this part of the conversation. Jeannie, you might have received the phone call from Mrs. Jones in the palliative care clinic, and how would you respond?
I think I would respond by, either giving her a call or if time allows, even jumping on a video visit with her. And again, if time allows, in the ideal world, I could even have, it could be a co-visit with Lucia and I, social work perspective and nurse practitioner. And then I would ask a lot more about specifics about her nausea and constipation, and thinking maybe does this have to do with the stronger pain medicine that was started, like an opioid, in which case we might need to start some medications to help the nausea and to help the constipation, in which we could discuss and make sure that the medication management of that is good. And then it would also be looping in Lucia to talk about support groups. And if Lucia wasn't able to join me, then I would be able to talk about that cancer support groups are often and so helpful for so many of our patients, going through and being able to really connect and get support from people who are also going along a cancer journey.
And I can add to that. Oh, go ahead, Ramy. You go ahead.
I was just going to say, just to echo both what Jeannie and Judy said earlier, the beauty, one of the beauties of palliative care is the ability to do joint visits. So whether it's me and our clinic nurse, or me and someone like Lucia, our social worker, our chaplain, we can ask those questions at the same time, in the same visit. And many times, even though I've been doing this for some time, my social worker will ask a question. I was like, oh my gosh, I can't believe I didn't ask that before. That was the key question that's missing in all of this. Or like Jeannie mentioned earlier, she was already thinking about potential side effects of medications and how she probably, in her expertise, would have preemptively counseled Mrs. Jones on what to look out for, what might be done if these side effects are realized, and therefore we can address them even before they come out, which is always better. So yeah, to go off of what Jeannie said, with side effects to pain medications, we do often use things like laxatives to help with the constipation. We counsel on nausea to see how much a person is feeling. That differs from person to person, is highly variable. But we can address them as it goes. And again, going back to finding that balance that Mrs. Jones defines for herself in terms of symptom control. And Lucia, I'm sorry to cut you off. You're about to say something.
No, not at all, not at all. And I do echo what you say. I think palliative care is very much a team sport, and we rely on our colleagues heavily. And it's lovely to be able to do those joint visits and come from our different perspectives to care for these patients and families. I was just going to expand on what Jeannie had said. Mrs. Jones had mentioned support groups and being interested in those, and that's something that I or other people on the team could also provide those resources of how to connect to support groups and what that looks like in the community.
Anything else? Is there anything else that anyone wants to add to how you might counsel Mrs. Jones going forward?
I'll also say that in all of this, yes, there is a reason why the oncologist referred Mrs. Jones to palliative care. It sounds like pain was that starting point. And often we spend a good amount of time up front to discuss what's on the forefront of her mind. But all the while, we're developing a relationship. We're getting to know Mrs. Jones. We're getting to know her experiences. And like what Jeannie said, she started off with this, her hopes and her worries for the future. And all the while, I often see palliative care as a longitudinal companion alongside Mrs. Jones and her family with this journey of illness. I often say that, hey, when things are going well, we want to be there to celebrate with you. And if things are a little bit more difficult than we'd have expected or would have hoped for, we're here to try to do our best to support you and your family. So I never want to discount visit after visit the relationships that are being formed. And I still remember this from our nurse who joined us last year during this session. We are a care team and we have different roles. And the most important person of the care team is the patient herself, right? Her voice is what matters most. So I just wanted to highlight the importance of that.
And I'd like to just tack on to that, Ramy. Thank you for saying that so well. But I also find that you mentioned the longitudinal relationship over time. I find that someone's needs change over time. It's not, something that we discovered the first day that stays static. All of us are changing people. The illness is changing. The treatments are changing. The way we're feeling with them are changing. The way our relationships with the people in our lives are changing. So our ability, and I'm so thankful for this, to come back and be with people and find out what's going on now and what would really serve right now. It really makes a big difference. So I'm grateful for that as a part of palliative care.
I just want to throw in a comment too that, part of the beauty of having a team of people is that people connect differently to different people. And so sometimes, a patient will have a fantastic connection with the palliative care doctor and start asking them questions that maybe the social worker should be answering, but that's where they feel the clearest rapport. And so as a team, we can field those questions to each other. Sometimes the person is just going to be connected to the chaplain and that's really who they want to talk to. And so again, just the beauty of having a team that is working together for the benefit of this person. Any other comments before we go on to questions from the audience? All right, then Gail, I think we will go ahead and start answering some of the questions in the Q&A. Again, with just a reminder, if you have a comment or a question, type it into the Q&A.
Great, thank you, Redwing. One question is, what is the best time to tell, in this question, particularly a cancer patient, about palliative care? But I want to open that up. Like, when is the best time to tell any patient with a serious illness about palliative care? And Jeannie, I'm going to start with you.
You know, I think that there's no specific timing that is absolutely necessary. I think when, you know, as palliative care is a discipline that really focuses on maximizing quality of life in a serious illness, it can really be when that quality of life is compromised by the serious illness. It can also be well before that. You know, I think it's palliative care, you know, as a team-based care can really be at the start of an illness, in the middle, towards the end. It's really any time in the trajectory. What Ramy said earlier, what often is the initial entry point into palliative care is from a symptom, right? A symptom, often pain, associated with a cancer or serious illness. And then once we're seeing patients, then we can really dig into all the other, you know, all the other things that we've discussed that are affecting the person and their quality of life. So great question, and there's no easy answer necessarily, but just know that you know, there's a lot of actually data and research that shows the earlier, the better. The earlier palliative care is involved, we actually has shown that patients and families just have better outcomes in terms of their pain and their overall emotional well-being.
Yeah, and Jeannie, this is Judy here, chaplain, just tacking on. Thank you for what you said. I totally agree, but I just love the idea of talking about it really early on, just so you know what it is. It's not like we're trying to refer you anywhere, just letting someone know this is one of the things that's out there that's possible. And I think it'd be so great, because then it's sort of on the table as something that people can come back to, you know, depending on how they're feeling. But anyway, just that. Thanks.
One of the things that we do need to bring up is that palliative care, often it comes with the job. Redwing said it best. There's a lot of definitions of palliative care, and I think that's by design, because I don't ever want to limit this field, knowing how much we do for our patients and knowing that the needs are different from patient to patient. But sometimes it requires me or one of our team members to really go into depth of what palliative care is and what it isn't. Obviously, palliative care has in society and layman's terms, but also among our providers too, an association with end of life, an association with hospice, an association with death and dying. And that's doing a disservice, because my main goal is to achieve what we've been talking about here, quality of life and how a person wants to live, regardless of how long prognosis or life expectancy might be. So yeah, many times we have to jump over that hurdle or that barrier to clearly define palliative care. And then once they're in the door, I hear it so often from patients or their family members, why didn't we know about this sooner? Why didn't anybody tell us about your team earlier on? So if you're worried about, you know, to the author of that question, timing, just know that it's better to err on the side of being too early, if that's even such a thing, than too late.
Thank you, Ramy. So there's actually a lot of questions about the interdisciplinary team, and how do you guys keep in touch, communicate, keep up to date with each other? And what are some of the challenges working in an interdisciplinary team? And I'll start with Lucia.
Sure. So communication is so important. I think on the inpatient side here in the hospital, we have daily rounds where we all gather as a team and discuss our patients and discuss our plans for the day and kind of lay that out. But we do keep in close communication throughout the day, either whether that be going to in person for joint visits or calling each other on the phone or using some kind of secure messaging system. The communication is really key. So great question.
And is the referring provider part of the team? Ramy?
So yes, I mean, in broad terms, absolutely. It's part of the patient's care team. And after the patient is referred to us by a referring provider, I am, whether it's over message, ideally over phone after first visit, to say, hey, we saw your patient and this is what we did. This is how I see it going forward. This is what came up. People feel more comfortable with certain, Red Wing said it, with certain people compared to others. And if a patient is hiding certain things with their oncologist because the oncologist is the gatekeeper of chemotherapy and of treatment, and maybe they're putting their best face on, and then they come to us and a lot comes out of that. And the oncologist say, my goodness, I had no idea. It's important to have that communication. So we are part of that care team. The referring provider might not be a part of our interdisciplinary rounds or team meetings. We have a weekly meeting here on the outpatient side to go over our patients and to talk as a team. But yes, absolutely. And then just to go over the second part of that question in terms of getting along, and yes, we have different personalities. You'd be surprised once we have the same goal, and palliative care kind of attracts a certain person, we get along pretty well, I'd say, at least here in our clinic. So yeah.
Yes, I have to agree. I think palliative care clinicians and people who work in palliative care are the nicest people ever. So I'm not biased though. So Judy, we have a question for you. With a decline in people being associated with traditional religions compared to years ago, how has that changed the conversations with chaplaincy?
So I would say it's always seemed very diverse to me. There've always been a number of people who are really very, very seated in their own faith tradition, and that's extremely important to them. And that might really support them, or they might feel distressed that they're not as connected with it as they wish to be. And in those cases, the conversation is very much about the person's connection with their formal faith tradition, their religion, the community that they're a part of. If someone's not a part of a specific faith tradition, then we're looking at, well, what nourishes your spirits? What's real for you? What's most important to you? Why do you feel I would never just say point blank, why do you feel you're really here? But that's a question that I would be wanting to ask on a rather I'm trying to think of a way of saying this. It's a question I would want to ask. I might not ask it quite as overtly as that. If someone asked me, why are you really here? I'd probably say, what? What are you talking about? But I might start reaching for, what's really important to you in your life? What is it that matters to you? What do you care about deeply? What should I know about you as a person that will help me understand what's really important to you? And then I just listen, right? I listen, and I listen in a particular way. And I think everyone on a palliative care team knows this. Every one of you on this Zoom call, panelists, knows this, but you listen in a way that is with an open heart as well as an open ear. And you listen for little threads. Someone might just mention something like a throwaway comment on the side. They may tell you about one thing and then say, yeah, and then my brother was kind of funny that day. I don't know what's going on there. I said, well, tell me about your brother. Can you say more? And maybe there's something really important there for that person. Don't know. So little by little, together, we try to find what is it that matters the most? Coming back to the question that several of you have said already, what are you most worried about right now? What's your biggest concern? What are you hoping for? So I'd say that.
So we have some more, I would say, clinical questions. How can we utilize the palliative care process for heart failure patients? It's not as widely used as it is in cancer, but insight is appreciated. And Ramy, I'll go with you.
Yeah, palliative care has made a lot of progress over the last couple decades. I know I'm standing on the shoulders of giants when it comes to the field and how far it's come. And unfortunately, despite the progress we made with patients with cancer or lung disease and other diseases, we've seen that in the data shows actually the inverse is true for patients with heart failure. And unfortunately, later referrals are happening. The referrals within the last 3 days of life for heart failure patients have increased over the last decade compared to other diseases or conditions. And so it has been, at least here at the Palo Alto Medical Foundation, one of my initiatives to introduce palliative care earlier on with our cardiology colleagues, tracking data and trying to get us through the door sooner, knowing full well that when heart failure reaches a certain point, the prognosis mirrors that of late stage cancer and the symptom burden. We think cancer pain is so bad, and it is. And patients with heart failure have an immense symptom burden with shortness of breath, with nausea, and forget physical symptoms, being in and out of the hospital, being afraid of their heart failure getting worse to land them in the hospital. That's a fear that they deal with day in and day out. So absolutely, thank you for bringing it up. We need to do better with palliative care and in cardiology to deliver quality palliative care to patients with heart failure.
How can people go about finding a palliative care team, or creating one if there's enough interdisciplinary team available to them? Lucia, I'll start with you.
Yeah, so that's a great question. I usually recommend for people just to ask. So if you know about palliative care and you're at a different clinic or in a different hospital, ask for, could I have a palliative care consultation? And then to see what comes your way in terms of a team. I also think there is a wonderful resource out there called Get Palliative Care. I think we're going to share that a little bit later on, but that's a way where you can look up, nationally where palliative care programs exist and potentially link with them. As for starting them, that's a great question too. In some ways, we are one of the newer specialties in medicine, and so we are still growing ourselves. And there is a lot of opportunity and still a lot of potential for palliative care, especially, in my opinion, out in the community settings. I think that's going to be the next big push to get palliative care out to people in communities.
Thank you. In terms of communication with families or healthcare agents, is there one point person? How does that work? And Jeannie, I'll go to you.
So, I think how we communicate with patients and families is really established in that first visit when we're asking them certainly who's important to them, who is their network of support. And then hopefully we've had, the conversation with them of who do you want involved in your care? And who is okay for us to communicate with about your care. And part of that, something that Lucia brought up earlier, which is designating a surrogate healthcare decision maker. And that is certainly, who the patient and the person really wants us to communicate with. And this is really, really important to do early on, as early as possible, really, because there's, we always worry about if you're not able to communicate, if you become really ill suddenly because of your serious illness. We need to be able to have an established rapport with someone who you trust that we can communicate with, and also who can make some healthcare decisions if you're not able to make them yourself. And as long as you have designated them verbally to us, it doesn't, I mean, ideally we have an advanced care directive that grants that person healthcare power of attorney. But if that's not available to you, or that hasn't happened yet, you can verbally designate a healthcare decision maker or healthcare surrogate decision maker. And also, who else would you like involved in your care? And we know that it's not always just one person, right? Families and all of us come with support systems. And so there's often, you know, a dyad, a triad, or more. There's often more people. And sometimes when there's large families, we do ask for sort of one designated person that we can then communicate with, who then can be responsible for communicating with everybody else in the family system.
Thank you. What happens when,
Sorry,
yes, go ahead,
I
Ramy.
add one thing, because I know culturally speaking and from family to family, there might be kind of, I want, you know, a person wanting all their children to be involved, or another member of the family, a matriarch or patriarch in the family to be involved. I will say that if, and I often say this, if there's more than one person listed as a durable power of attorney, then I think it requires a lot more in terms of guidance or saying what treatment decisions are acceptable to you or not in the event that you're not able to make decisions for yourself. So even more than, you know, normally or usually, you need to be more clear about your wishes if you're having more than one DPOA on that advanced directive form.
Thank you, Ramy.
And I would just add to that, Ramy, that if you are going to have more than one person, that you have conversations with them at the same time so that people are on the same page.
Yeah.
So if somebody is new to palliative care because they have symptoms, but then their symptoms are well controlled, their disease is stable, like what happens then? Do we pull back? How does that relationship flow back and forth? And even into, let's say, if somebody goes on to hospice and then quote unquote graduates hospice, like what happens there? Will palliative care come back? So Ramy, would you like to take that?
I'll start, but I also want to hear from the other panelists too. Hey, I said it before, and when things are going well, we want to celebrate. So often, you know, even if we don't hear from a patient or their family member for some time, I often just reach out via phone, or someone in our clinic will reach out via phone just as a check-in. How are things going? Hey, they're going well. I was able to do this. Great. You know, we have our patients sending us pictures of their trips when pain is better controlled, or telling us that they went back to work. So absolutely, it's dynamic, it changes. And as the needs change, yeah, our role might change too, but it's my philosophy that, you know, we have a hard time letting go, so we'll still be involved. Red Wing, do you have anything to add to that?
Not really. I think that, you know, I think it's sort of like once a palliative care patient, always a palliative care patient. I mean, these are about relationships. And those relationships can continue throughout a disease as disease processes go up and down. We get better, we get worse. But, you know, ideally, we do maintain some relationship. And, you know, for some people, when they are referred to hospice, in some situations, their palliative care physician can still be the physician of record in hospice. That doesn't always happen, but it happens sometimes. So there are different ways to maintain those relationships.
And I also wanted to chime in and clarify the term graduating hospice. I think it deserves some clarification. I think what we mean by that is that a patient no longer qualifies for hospice, or they no longer meet the criteria. You know, things may have changed in their health condition, and so, or they've decided that they would like to continue with aggressive care or curative treatment. And so I think, again, palliative care is there, ready to receive them, within their goals.
Yeah, thank you. I would just add to that, I've heard it said that hospice is a subset of palliative care. It's much larger, but it's not as though palliative care goes away because hospice is happening.
I think one of the ways I like to look at it is that hospice is a kind of palliative care in the last 6 months of life, whereas the broader palliative care can be anytime, at any time during a disease, but hospice is very specific to the last 6 months of life.
Lucia, one more question for you. Is palliative care covered by insurance?
Great question. Yes, most, I would say like 98% of the time, yes. I can't say with certainty with every insurance plan, but most insurances do cover palliative care.
Okay. So in the Q&A, somebody dropped the website for Get Palliative Care, which is another way to find palliative care resources in your area. Somebody did ask, do all hospitals have palliative care? And no, not all hospitals do. We're lucky in our region. Most hospitals have inpatient palliative care. Some have outpatient palliative care. To the degree of what kind of how big the interdisciplinary team is varies from hospital to hospital. So Get Palliative Care is a really great resource if you live outside the area. I think later we have a slide of kind of the local hospitals, health systems that do provide palliative care. I'm sorry that we don't have time for everyone's questions. But they were all really great questions, and thank you to our panelists for answering them so well.
Thank you, Gail. And yes, we do have a slide of just kind of a map of palliative care in the Bay Area. We, as Gail said, are incredibly lucky that we live in a place where there's palliative care pretty much everywhere. Although I have to say, most urban areas in our country, big city hospitals do have at least inpatient palliative care teams. Outpatient might be a little more challenging. You will get a follow-up email, everyone who has joined this webinar, with a little more detail about how to contact these various palliative care programs around the Bay Area. Hopefully that will be helpful to you. You will also receive a post-session feedback survey, which we really hope you will fill out to help us understand how to improve this so that we can continue with our annual webinar. We're thrilled that so many people are interested in this subject, want to know more about it. One of my pet mottos is, and I did learn this from Diane Meyer, who I kind of consider the queen of palliative care, is that demand creates capacity. And the more people who understand what palliative care is, why it's important, and continue to normalize conversations about palliative care, the better it's going to be for all of us. So again, thank you so much for being here, for showing up today. You will get some more resources in your email, and have a safe and happy Thanksgiving to everyone. Take care.